just to welcome you all. Oh gosh. Welcome you all to our Landscape of Practice meeting. Thank you all for finding the time, particularly in the month of July. Also recognizing that in Ottawa, there is currently a tornado warning. So if anybody needs to take cover, please do so. And as a reminder, we will be recording the session. We'll only record the first part of Michelle's talk, and then we will stop the recording for the Q&A. We've had requests to share it after. So before I begin, I'd like to acknowledge that the land on which Carleton University is located is on unceded, unsurrendered traditional territories of the Algonquin Anishinaabe Nation. And I also want to recognize the diverse histories and cultures of all Indigenous peoples across Turtle Island, and would encourage you to reflect on the traditional territories on which you're currently located. I know we have a couple countries, different countries involved, and certainly different provinces and territories in Canada represented. So just as a brief overview, I am going to just sort of talk quickly about the funding that has allowed us to do this landscape of practice. And then I will introduce Michelle. We'll have time for questions after the talk. And then we have the option to go into breakout rooms for some discussions. And we'll explain that later in the program. So again, I want to acknowledge the Public Health Agency of Canada through their call, Preventing and Addressing Family Violence, the Health Perspective. They have supported this work. And what we're doing through this project is aiming to leverage trauma and violence-informed approaches to physical activity to support individuals who have experienced family violence. And again, this is through community-based participatory research. And I don't think I actually introduced myself. I think I know many of you on the call, but maybe not all. My name's Francine Jarek, and I'm an associate professor at Carleton University in Ottawa, Canada. And I have the privilege of leading the team that is doing this research with too many fantastic people to name at this point. So I'd like to introduce Dr. Michelle Pebole. And Michelle, I feel like I say it wrong every time. Was that correct?
That was perfect. It's spot on.
So I have been fortunate to get to know Michelle over, I think, the last, couple years. And she is a postdoctoral research fellow in polytrauma at the VA Boston healthcare system. And her research focuses on the impact of physical activity and psychological trauma on physical, mental, and psychosocial outcomes, specifically looking at veterans exposed to interpersonal violence, as well as understanding best practices for implementing trauma-informed physical activity programs. So again, her work is really important, quite central to a lot of what we're doing. And we've had so many discussions around trauma research and more broadly, the need for trauma-informed approaches to engage in this work. And just before I sort of pass the floor over to Michelle for the rest of this talk, I do want to provide a trigger warning that Michelle will be talking about sexual violence and focused, given that her research is focused on that population. So if you need to take some time to step away from the computer, if you need to leave, please do whatever you need to do for self-care. And with that, I will go ahead and pass the floor over to Michelle.
Okay, great. So again, thanks all. I want to say thanks for having me. It's really, really wonderful to be here. So I feel really privileged to be able to talk to this group. I don't often get to talk to people who work in the areas of both physical activity and trauma-informed exercise. Often I feel like I'm talking to a psychologist or I'm just talking to exercise people. So I'm really excited to be able to talk about my work, but then also hopefully have some good discussions and learn from all of you with your experiences. So I'll be talking today about exercise perceptions among women survivors of sexual violence. I have a smattering of affiliations here. I work at the VA Boston Healthcare Center. I also have an affiliation with Harvard, but this work was done while I was a doctoral student at the University of Illinois, so that is why you see all of those affiliations there. So I just wanted to start with a brief definition of sexual violence. This also is reminding me, I was planning to just go through these slides, but certainly if there's clarification or you have a question, I'm happy if you just let me know and I can answer them as I go as well. So brief definition of sexual violence, and I always think it's important to do this because I've often found when I talk to different groups of people that everybody has a little bit of a different definition. And so for the sake of this project and this presentation, I'll be using this definition, which is per the CDC here in the US. So that's defined as a sexual act that's committed or attempted without freely giving consent of the victim or against someone who is unable to consent or refuse. And so one important note for sexual violence, oftentimes people have an affiliation of sexual violence being purely physical, but it's also inclusive of psychological violence. So this includes things like harassment that may not be physical, as well as things that are physical, like an assault. So I'll be talking about both of those things throughout. So first thing I also like to talk about is the prevalence of sexual violence against women. It's a really big public health concern. The bottom line is this is happening to more women than it's not happening to, very unfortunately. But I also think it's really helpful to know the incidence rates of these types of experiences among women. So this data is from the National Inno Partner in Sexual Violence Survey from 2016 and 17. So it is from the US, but you'll see contact sexual violence here as defined as rape, sexual coercion, or unwanted sexual contact. It's happening to over half of women in the United States. When we look at rape itself, it's just over 1 in 4, so about 26% of women. Sexual coercion, just under 1 in 4, so about 23%. Unwanted sexual contact, we're at, again, almost half of women in the United States have experienced, so 47%. And then sexual harassment in a public place, it's almost 1 in 3 women. And unfortunately, another thing that's really important to think about is how people experience often multiple types of violence. It's not often just one type, it's often multiple experiences throughout their lifetime. So this is a really big health issue, and these things have really big implications on physical and mental health. So again, people who experience sexual violence tend to have a lot of diverse health outcomes, and it's hard to really talk about these without talking about all of them just a little bit. So a lot of times when we hear about sexual violence, we hear about things like a mental health diagnosis. So oftentimes this looks like PTSD, anxiety, or depression, which can be formally diagnosed or just being experienced. And there's often things that are also not affiliated with a diagnosis per se, which are also really hard for people. So these are things like emotion dysregulation, poor body image, and disordered eating, among many others. Oftentimes we don't talk about the physical health implications of sexual violence, and so those can also really compound and are also really challenging for people to deal with. So people who experience sexual violence experience high risk for cardiometabolic disease, a lot of inflammation and inflammation-related disease. Chronic pain is a really big issue, and chronic pain also contributes to a lot of functional impairment. So it's often really hard for people to complete daily tasks if they're experiencing a lot of chronic pain, and that's a really big issue for this group of people. Other really important things to think about as well when we're talking about sexual violence is the psychosocial impact. And these things make it really hard for people to get treatment or care for after experiencing sexual violence, as well as in general, it makes them feel pretty isolated in their experiences. So these are things like social isolation, shame, stigma, self-harm, and suicidal ideation. And so we know people who experience sexual violence often don't disclose their experiences to other people and often find it hard to engage in care because of fear of not being believed or other issues like that. So all of these things kind of work together, and they can really negatively impact people as they're experiencing the outcomes of a sexual violence event. So one of the things that I think about often in my work, and this is kind of a function of my training, so I often work in hospital-based settings where I'm working with healthcare providers or psychologists. And so I have just kind of this figure, which I'll talk through, about how we can integrate physical activity as a part of treatment plans for people who've experienced sexual violence. So to start with this schema that I've made up, I just have a woman who's very unfortunately experienced an event that's included sexual violence. And oftentimes what happens is those health impacts that I talked about, they often can perpetuate chronically and get worse over time. So these aren't things that just happen and then the people recover from them. It often gets worse as people get older if they're untreated. So right now in our treatment schemes, when we talk about getting treatment for people who've experienced sexual violence, primarily what we talk about are mental health focused treatments. And these are things like trauma-focused therapy, cognitive behavioral therapies, or group therapy. And there are others, but those are mostly the main ones that the healthcare system would refer people onto. These treatments are good if you complete them. There are a lot of things that are really hard about these treatments as well. So there's really low engagement. If anybody has been involved with trauma-focused therapy, it's really it's a big mental hurdle to enroll in them, and they're quite hard to get through. Um, that often leaves people dropping out at high rates. So oftentimes people don't complete these treatments. And these treatments are all really focused on mental health outcomes. So they don't often address the physical health outcomes that people are experiencing affiliated with violence. So one of the things that I often think about, and this is what a lot of my work has focused on, especially recently working at a VA hospital, is how we can add physical activity to our toolbox of things to help people who've experienced sexual violence. And from the information that we have about people with PTSD, we know that physical activity can improve physical health, mental health, social connections about people who've experienced violence. And another really nice feature of physical activity-based interventions is oftentimes people will be much more open to engaging in other treatments if they're coming in for physical activity to start. So for example, I used to work as an exercise physiologist for an exercise trial for veterans with PTSD. And oftentimes I would see people pretty consistently who were really, really adverse and didn't want to go seek mental health care. But I would come and see them. They would get used to seeing me. I would give them referrals on to mental health treatments or any other type of primary care or other health issues that they needed help with. I could help encourage people to seek treatment and do warm hands off, so that they could engage in those other treatment modalities as well. So I often, when I'm talking to exercise science groups, I often really lean into this, but I feel like this group has an innate understanding that oftentimes physical activity is often not safe for women and often perpetuates violence against them. It's not a safe place, but by any means. So these are just some examples. The first one being Larry Nasser, who very unfortunately abused many women at the USA Gymnastics. And I've provided much more examples because I don't like bringing them up for many reasons, including I don't want people to think that this only happens in elite sport levels, because it happens on all levels of physical activity engagement. Another example is Adidas recently found that 92% of women in a survey felt unsafe while they were out jogging. And this is with good reason. We've had very many incidents of women being killed while they're out jogging, as well as many other unpublished incidences of women experiencing violence while they're jogging around their neighborhoods or at the gym, or have you. And there's this kind of growing social media engagement about gym spaces being uncomfortable for women in general. So again, I often harp on longer on this slide, often because people aren't always aware of trauma-informed approaches or engagement, but I know that this group has a baseline understanding. So what I'll just say is that one of the best things we can do as exercise professionals, and something that I try to repeatedly tell people that's important, is to think about how we can make spaces more safe for people who've experienced violence. And so one of the main ways that we can do that is incorporating voices of people who've experienced the violence, understanding their thoughts and perspectives, and integrating those into how we create physical activity programs. So I'll talk about this project, which is trying to do that for survivors of sexual violence. And I would also say that there are so many people in this group who do this really well. So again, for Francine and her group, I would highly recommend any of her research as well if you're interested in this topic. So again, this is just talking about the study that I completed. And this is part of my dissertation. It was a cross-sectional online survey. And again, my goal in doing this was trying to get feedback from people who've experienced violence about how they thought about physical activity, so we could use that information to create more inclusive spaces for people who've experienced violence. The inclusion criteria for the study was having a biological sex of female, having experienced some form of sexual violence in their life, being between the ages of 18 and 65, and being physically located in the United States. I measured a lot of different things with this survey. I will just report here on things that are really relevant to these analyses. So sociodemographic information, PTSD symptoms, exercise perceptions and preferences. And I'll talk just a little bit about how we measured those. But to give you an overview, to measure exercise perceptions, we talked about, sorry, I've just got a notification. So to measure exercise perceptions, we use a scale called the Exercise Benefits and Barriers Scale, which I'll talk about more in depth later. And we added an open-ended question to that scale, which basically asks, do you perceive any benefits of exercise that weren't included here? If you do, please write those in. So it had an open-ended section as well for the benefits and the barriers. For exercise preferences, we asked questions that we were interested in, like, for example, questions like, would you be interested in an exercise program made for women survivors of sexual violence? And then other questions about exercise programs, like what intensity exercise do you prefer? What type of exercise do you like? Questions like that. And again, I'll go more into those as I talk about them. And out of interest, we did comparisons by PTSD status. So we measured PTSD status with the questionnaire called the PCL-5. And that questionnaire has a cutoff. So if you score over this cutoff, you're considered having provisional PTSD, which just means you have higher trauma-related symptoms, versus if you didn't meet the cutoff, you did not meet that cutoff, so you have no PTSD per the survey. So this is some sociodemographic information from the sample to give you a sense of who responded to the survey. We had a total of 355 women who responded. So this is entirely a cisgendered sample, primarily pretty young. So primarily between the ages of 18 and 35, primarily white and non-Hispanic and heterosexual. So we had a large portion of the population that, that had responded to the survey meet criteria for provisional PTSD. So over 83% met that cutoff for having provisional PTSD. And then for experiences of sexual violence, we had 70% experienced sexual harassment, 54% experienced assault or rape, 80% experienced other violent experiences, and then we had almost 70% of people experienced multiple types of violence. Let's see. Okay, there we go. So this is the perceived benefits and barriers scale. I'll take a minute to just explain this. So you'll see each part here, there's a top and a bottom separated by kind of these blue here. So this top part is the perceived benefits scale, and the bottom is perceived barriers scale. And then within those scales, these are each subscale. So life enhancement is a subscale of perceived benefits. Exercise environment is a subscale of perceived barriers. So that's kind of how it's organized. And then for the scoring, so each one of those subscales has multiple items within it, and they're all scored from a 1, which means strongly disagree, to a 4, which means strongly agree. And what I've done is I've just standardized the scores for each subscale so we can compare them to each other. So a 1 would mean a strongly disagree for that subscale, and a 4 would mean strongly agree. It's a little bit confusing, so I'll just do an example with you. So for life enhancement, for example, if the score was 1, that would mean I strongly disagree that life enhancement is a perceived benefit of exercise. If the score was 4, it would mean I strongly agree that life enhancement is a perceived benefit of exercise. So that's kind of how you think about these scorings. And I'll talk you through them as well. So these are just baseline information from the sample without any comparisons. I'll talk you through things that stuck out. So the highest benefits, so the things that scored the highest for the perceived benefit scale were physical performance and psychological outlook, meaning these are the things that people thought were the highest perceived benefits of exercise. Again, we also had an open-ended section where people could write in responses. And so I've just picked out some quotes from these responses to demonstrate each one of these findings here. So this quote is, "Exercise makes me feel strong." This came up a lot, people saying exercise made them feel strong and in control of their bodies. For perceived barriers, the things that had the highest score were exercise environment and heart exercise, meaning that those were the highest scored perceived barriers to exercise. And again, the quotes that I've pulled out here that help demonstrate those are, "I need to exercise, but I'm in pain all the time. And I get nervous. I feel like something bad is going to happen." So we had a lot of people respond something to the effect of, I would like to exercise, but all these chronic conditions make it really hard. And a lot of people talked about safety concerns as well. And I'll just say too, if you're a person who likes to look at research, I would put these QR codes up in the right-hand corner, which if you scan, it should take you to a published manuscript based off of this data, if that's of interest. So those are all over this presentation. So I've done some comparisons. Again, this is the same scale, and I've just compared people who met provisional PTSD standards and then people who didn't. And I'll talk you through these results as well. So I'll just highlight that people with PTSD were less likely to view physical performance and preventative health as perceived benefits of exercise, and they were more likely to perceive social interaction as a perceived benefit of exercise. For the perceived barriers, people with PTSD scored higher, meaning that they viewed that the barriers were more salient to them on almost all of the barriers, including exercise environment, time expenditure, and family discouragement. So I'm going to talk briefly too about exercise preferences among this group. And I've highlighted some things that I thought were really interesting and relevant. So the first question is about interest in exercise programs made for them. So this is the question that said, would you be interested in an exercise program made for women survivors of sexual violence? With the answers being yes, no, or maybe. So this light blue is yes, this darker blue is maybe, and this red is no. So for the entire sample, without doing any comparisons, you'll see that most people responded yes or maybe. So 55% said yes, about 38% said maybe, and almost 6% said no. So interestingly, when we compared by PTSD status, we found that people with PTSD were actually more likely to say yes and less likely to say no than those without PTSD. So people without PTSD were much more likely to say maybe or no, meaning that people with PTSD seem to be much more open to engaging in these types of programs than people without PTSD. On the whole, too, what we found, some trends with preferences were that people tended to prefer exercising locations being at home, alone, with a female instructor, between 3 or 4 times a week with moderate intensity exercise and sessions lasting for 30 minutes to 1 hour. And then I've done some comparisons by PTSD status again. The first one being instructor sex preferences. So here you'll see people with PTSD. There is about 80% of people with PTSD preferred female instructors. There's about 9% preferred male, and then there was about 6% had no preference, versus people without PTSD. It's about half preferred female, just under half had no preference, and it was about 1% said male. So altogether, this means that people with PTSD tended to have stronger opinions about having a specific sex, whereas people with PTSD seem to be more flexible. Although on the whole, we see that female instructors were by and large preferred by the entire sample. By other comparisons for preferences, we found that women with PTSD generally preferred at-home exercises with moderate intensity exercise or moderate to high intensity exercise intensities and longer exercise session durations. So I have just a really brief discussion here, and again, I'm really interested to hear any thoughts that the group has as well, but just some things that me and my research group and what I think about when I think about future work. I think that these results represent foundational knowledge in this area. So to my knowledge, we haven't systematically assessed how people who've experienced sexual violence really think about exercise. And I think this is a really important first step, which we can use to create even more knowledge on this topic so we can create more accessible physical activity spaces. I think some of the things here are really relevant for implementation and promotion of exercise programs for people who've experienced violence. And I'd also say for anybody who works with the general population and exercise, I think these themes are also really relevant there, given that we know people experience sexual violence, but they might just not disclose it to people. So even if you're working with the general population, you're probably also working with trauma survivors and you just don't realize it. So I think these are relevant for working with all people. And these are things, so the first thing that also really stuck out was that there seems to be a lot of interest in programs for people who've experienced sexual violence. And this was especially true for people with PTSD, which was a surprise, given that we know people with PTSD are often a lot harder to engage in these types of programs. But it seems if we can offer thoughtful programs, people would be interested in being involved in them, which I think is really encouraging. I think the information from the perceived benefits and barriers of exercise really highlights the need to highlight social, psychological, and physical benefits of exercise. Something that stood out to me too was the perceived social impact of exercise among people with PTSD. So it seems to me that people with PTSD kind of understand that physical activity might be a really nice way to engage socially with people in a low, like there's not much threat involved with physical activity usually. So it could be a really nice way for people to connect with each other. And so I think highlighting those things would be really helpful and important rather than highlighting things like weight loss, which often gets emphasized in physical activity interventions. I think this also really highlights the importance of having exercise staff who are knowledgeable about trauma in general, not only about being trauma informed and how you talk to people, but also engaging with people who have multiple chronic conditions, which might make them it might make it harder for them to engage in activity because of pain or other functional impairments that they have. So this is really important and I think central to successfully implementing these types of programs. Some things that I think about for future work, I think it's really important, and this is something that I have really reflected on moving forward to be more inclusive of diverse groups of survivors. So this sample was only really a small part of the people who experience sexual violence. We know people with minoritized identities experience it at much higher rates. So I think moving forward, it's important to be mindful about that and intentionally reach out to other populations and communities that experience high groups of violence. I think also it's good to think about ways that we know that people feel unsafe. So we know people feel unsafe. We know there's a lot of barriers for people who've experienced sexual violence. And so I think trying to identify specific ways that we can enhance safety and kind of combat the barriers with physical activity for people who've experienced sexual violence would be beneficial. So those are just a brief discussion. And then I like to ask these reflections questions as well. These aren't meant to put anybody on the spot, but these are just things that I think about or I try to think about consistently in my work and in my day-to-day life. I think it's just nice to think about how we can be better as researchers and how we can be better for the people that we work for. So they're written as people working in research, but certainly if you're not a researcher, they're applicable to any space that people work or live in. So first, how do you think women survivors feel participating in your research or work? How can you make your research spaces safer for people who've experienced sexual violence? And how can you change your research to be more inclusive? And again, I'm happy to hear ideas for this, but I don't mean to put anybody on the spot. They're more just things for you to think about as you move forward in your work. And then I'll just say a quick thanks. This is my dissertation. So these are all people on my committee. And this was funded by the American College of Sports Medicine. Again, if you're into research, that QR code will take you to my ResearchGate. There's a lot of resources on there, but you're also free to reach out to me as well. I'm always happy to talk and share things as well. So yeah, thanks again so much. That's all I have.